So we are starting case number 59 from Odell, which is about oral submucous fibrosis. The description says difficulty opening the mouth. So it is a case of trismus also, secondary to OSMF. A 40-year-old Indian man presents with limitation of mouth opening. You must identify the cause and institute appropriate management. So origin is Asian, and the picture, difficulty opening, it only should hint about OSMF. Difficulty eating, he cannot open his mouth wide enough to place as much food inside as he could before, and also has difficulty chewing. History of complaint says that he has noticed a reduction in the mouth opening over a period of several years, but has never sought advice. It has not been overtly painful, although during the same period he has felt an uncomfortable burning sensation in the buccal mucosa on eating. So burning sensation on oral mucosa while eating, uncomfortable, again OSMF. Otherwise fit and well. What are the causes of limitation of the mouth opening? So trismus is defined as clinical sign of limited mouth opening less than 35 mm, which can result from wide variety of causes, which we just discussed in the last case. Historically, definition of trismus was spasm of muscles of mastication, but the broader description of limited opening is more relevant clinically. It's usually reversible and most often results from treatable causes such as trauma or infection. Like we read before, usual ones are reversible ones. It can be associated with other clinical symptoms such as pain in the jaw and difficulty performing activities that involve opening the mouth, such as toothbrushing or eating. Irreversible causes of trismus such as OSMF or ankylosis after trauma may be progressive. That means it keeps on deteriorating in their early stages and do not respond to currently available treatment strategies. The causes of trismus, case number 8, which we just read, and this case number 59. Reversible, irreversible. Reversible, inflammation in and around TMJ, muscles of mastication following wisdom tooth surgery. Soft tissue infection around the jaws or TMJ, usually dental in origin. Then TMJ, myofascial pain dysfunction syndrome, trauma, example, fractures of the mandible or zygomatic arch, or soft tissue injuries, and tetanus and tetany. Irreversible, extraoral causes, acquired fibrosis caused by burns or irradiation, oral submucous fibrosis, mucosal scarring, like example found in epidermolysis bullosa or scleroderma. Congenital ones, all are rare. Example, syndromic such as masticatory muscle underdevelopment in trismus pseudocamptodactyly syndrome, or non-syndromic such as neurological brainstem digenesis. Intra-articular causes, acquired ones, post-traumatic ankylosis, ankylosis secondary to septic arthritis, neoplasms in and invading the TMJ, congenital-like rare abnormalities of craniofacial structures, such as Apert syndrome, or non-syndromic, such as neonatal infections. So here, reversible, irreversible, again divided into extra-articular, intra-articular. It is similar to the table from case number 8. Now, this patient, what questions would you ask? Patient should be asked whether there has been trauma or irradiation to the skull, TMJ, or face, and whether there have been episodes of swelling of the face or around the joint. He should be also asked whether he uses betel quid, which is areca nut or pan. Patient gives no history of trauma, irradiation, inflammation, or infection. However, he has been a betel quid chewer for more than 20 years. Extraoral examination, mildly anemic, no facial asymmetry, no evidence of scars or inflammation over TMJ, no tenderness. There are no clicks, crepidus, or tenderness associated with TMJ, and no mandibular deviation on opening the mouth. What measurements would you take? Normal interincisal mouth opening is 35 millimeter. Measurement will provide baseline reading against which judge treatment efficacy or trismus progression, because OSMF is a progressive disease. It deteriorates over time. Here, the patient can only achieve 17 millimeter, almost half of the normal interincisal opening. The oral mucosa is shown in figure 59.1. Here you can see bands of fibers. Here you can see the lower mucosa where bands of hard, pale, scale-like tissue are visible below the epithelium when lip is everted. And if you were able to examine the patient, you find that he also has some reduction in mobility of the tongue and cannot protrude it very far. Most of the mucosa feels firm. So diagnosis is presentation are characteristic of OSMF. Gradual limitation of mouth opening and restriction of tongue movements are seen in beetle quid user, who shows typical mucosal blanching and fibrosis presenting as bands in the buccal mucosa. While other features of OSMF might be seen, in the early stages, some patients complain of vesiculation of the mucosa. In severe cases with extensive tongue involvement, filiform papillae are lost. What is beetle quid chewing? A habit practiced by many people in Indian subcontinent, Southeast Asia, subparts of Africa. Basic quid comprises of paste of areca nut and slaked lime wrapped and tied into a packet in a vine leaf. So some people have this just without any vine leaves also. Areca nut contains alkaloids which have a psychoactive effect and make the habit addictive. The quid is usually chewed intermittently and lies in the buccal sulcus for long periods. Many users keep it in mouth all day and even sleep with quid in the mouth. It has been estimated that 10% of world's population use beetle quid, and chewing is a major health problem in many countries. Possible effects. The first possible effect is OSMF, oral and pharyngeal squamous cell carcinoma. OSMF in itself is a pre-malignant condition. Periodontitis, recession, root erosion, tooth staining, decreased taste sensation, possible worsening of asthma and possible association with diabetes and malignancy is also, associations are there. And we have what is the significance of the diagnosis, what else you should look for. It's a potential malignant disorder. Approximately 1/3 of the patients with OSMF have oral white patches, and dysplasia is present in mucosa of up to 16%. Malignant transformation to squamous cell carcinoma occurs in 5 to 8% of the cases. The second significant feature is restricted mouth opening. This is often progressive and responds poorly to treatment. In the late stages of disease, patient may be unable to open the mouth at all, and incisor extractions may be required to allow feeding. What are the investigations? Biopsy is required to assess the dysplasia. If there are lesions that raise suspicions of malignancy, red or white patches or areas of otherwise abnormal mucosa, they should be sampled for microscopy. So biopsy is a must. You have to refer these patients for biopsy to oral surgeon. Would you perform this patient's biopsy in a general practice setting? No, it should be because of high risk of carcinoma, you would refer. When you see the specimen from quid side, you would see epithelium well organized, stratification, maturation, and not particularly disordered. The epithelial layers are easily differentiated. There is an expanded basal cell layer comprising rather disorganized, small and darkly staining cells, which show an isonucleosis, nuclei of different sizes, and irregularly shaped, often angular nuclei. And towards the center of epithelium, there is a cluster of prickle cells between two dermal papillae showing early and single cell keratinization. And these features point to mild dysplasia. So dysplastic changes, basically knowing this is more than enough. They are not giving biopsy slides as such. It's a job of a specialist to analyze and give the confirmed diagnosis. No treatment regimen yields satisfactory results, and the aims is maintenance of oral health and prevention of complications. Treatment options, habit intervention is the critical one. Arecanut is the main etiological factor for OSMF. There are a number of other carcinogens. So cessation of the habit should be the aim. As a partial measure, discouraging tobacco in the quid would be valuable. This will reduce the risk of malignancy, but limitation of opening may still worsen. Cessation is best, but there would still be a risk of malignant transformation. And we have regular reviews. The only reliable method for detecting dysplasia and early malignant transformation, repeated biopsy may be needed. Muscle stretching exercises, these appear to give good results in some patients. And to be effective, muscle stretching exercise must be frequent and prolonged. Bite wedges or a screw appliance may help produce the forcible opening required. Effective exercises are painful and patients must be highly motivated. And we have intralesional steroids can be given within the lesion steroid injections. These have been used widely, but the results are not encouraging in most patients and any benefit may not be sustained. Surgical treatment, occasionally used as the last resort. The fibrosis extends deeply into the muscle, then surgery can be done. Excision of scar tissue is rarely possible. Post-operative scarring replaces the original fibrosis as surgery is usually followed by relapse. So the wound tissue after surgery also contracts. So there is no good cure of it even with surgery. Then we have nutritional supplements. Many patients are deficient in iron and vitamins. Dietary supplementation with these and carotenes or vitamin A may be helpful in reducing progression, but the effect is not marked. Experimental methods, the lack of effective treatments has led to trials of many compounds, including interferon gamma, but none has proven consistently useful. In general dental practice, health education regarding against chewing tobacco should be done. Chewing arecanut should be done. And the general dental practitioner can help specialist center to modify patients' high-risk behavior, reinforcing message to remove tobacco from the quid and encouraging patients to reduce arecanut and frequency of chewing. The importance of prompt referral and regular mucosal examination for dysplastic lesions and carcinoma has already been stressed. So this is more of the case of OSMF. Okay, this patient has a typical but late presentation of OSMF. What are the earliest features? So earliest features are relatively subtle and non-specific. There is typically burning of the mucosa and roughness and sometimes described as tiny vessels. And all or other parts of the lining mucosa may be affected. And these symptoms associated with beetle quid chewing should be regarded with highest suspicion. So if a patient has these vesicles, burning sensation, roughness of the mucosa, and the patient confirms that he chews beetle quid, then we should be suspicious about the presentation being OSMF. With this, we complete this short case on OSMF associated with trismus and intraoral precancerous conditions.